Well, thank you, Dr. Landis, for this very nice introduction. My name is Carsten Büning. As he said, I'm the head of the department at the Krankenhaus Waldfriede Hospital in Berlin. I'm a gastroenterologist with a special focus on inflammatory bowel diseases. So the topic of the microbiome is something that is very interesting for me. So I decided to talk to you about this topic. These are my financial disclosures. And these are the objectives that I have. I would like to give you some definitions and numbers on the microbiome. Maybe not all of you are so familiar with that. I would like to show you some important factors, how we can influence our microbiome. It is very interesting that we see a lot of diseases that we treat that have been associated with changes in the microbiome. And I would like to show you some unsolved problems regarding this topic. And then the question is, if the microbiome is so important for us, how can we influence it? Are there any ways to change it? So the microbiome is of great public interest, and you will see a lot of newspapers and a lot of coverages saying how important it is. And for example, over here, this is a book from Germany. It's called The Charming Bowel, and it's a lot about microbacteria, and it has been a bestseller for years now. And she's a very young college student, and she wrote a book about this charming bowel and the microbiome. So when you look at the NIH microbiome projects that have been funded throughout the last year, you will see a dramatic increase in the number of money spent on these projects. And you can see here from 2012 and 2016, the numbers have almost doubled. So when you have an idea what diseases the microbiome could be associated with, you might specifically think it should be gastroenterology. But if you take a look at the left, you see there are also other neoplasma, urogenital diseases, or respiratory diseases, where some physicians study the role of the microbiome in these diseases. And I think that is very interesting. Now, to give you some definitions and numbers, and I think this is very important. So the microbiome comes from the words of small, from micros, and bios, life. And so, not to confuse these two different topics, microbiota and the microbiome, as you can see here, the human microbiota is the aggregate of all the microorganisms that consist of a variety of bacteria, virus, fungi, and other single-celled animals that live in our body. So the microbiome is the collective genomes of all the microbiota. So that's maybe that you can discriminate between those two definitions. Well, if you look at the microbiota of the body, you have different systems where they occur. Maybe you start out with the skin. You have different bacteria located at the skin, for example, Staphylococcus epidermis. Then you go to the mouth, where you have another different population of bacteria, mostly Streptococcus. And then you add the GI tract. You're starting with Helicobacter pylori in the stomach, and then you go all the way down here with a lot of Lactobacillus and E. coli and Bacteroides. And you also have different bacteria in the urogenital tract. So a couple of years ago, it was thought that we have a lot more bacteria in the body compared to human cells. But now there's a new calculation that looked at over again. In our body, the bacterial cells are dominated by all the bacteria that are located in the colon. In humans, the human cells are dominated by red blood cells. So in 1972, they estimated that we have about 10 times more bacteria compared to human cells. But these colleagues now made a recalculation saying we almost have the same numbers of bacteria compared to human cells in the body. And so, in altogether, we have about 14 trillion bacteria that harbor us humans. And I think there's quite some interesting numbers. So, but there's more to come. This is a recently published paper in Nature, and they did some metagenomic methods looking at the number of bacteria again. And through this method, they found almost 2,000 uncultured bacteria that have not been known so far. And this changes our phylogenetic diversity of almost 300%, which is saying that there's so much to know about the microbiome, and we're far from knowing actually everything. So now you might ask, what influences our microbiome? Do we have different aspects of our life that might have an influence on the microbiome? And the clear answer is yes, it is. So it all starts out with age. The one reason is could be in utero, when we're not born yet, there's supposed to be a sterile hypothesis. But this has been challenged because we might even be confronted with some bacteria coming from the semen or the placenta. And as soon as we're born, there's a dramatic confrontation of the child with bacteria. And it kind of comes from the way of the child was delivered. If you have vaginal delivery, you start out with a lot of lactobacillus. If you have a C-section delivery, you have different microbiota of the skin. But then you start growing, and with the first 2 years, you get introduction of solid food, and this, of course, changes your microbiome. And then you go into puberty, you have sexual maturation, and here comes another sexual hormones that influence your microbiome. And in adulthood, you develop this called core microbiome, and it's quite stable over a long time. And then what you see, of course, during life, your intestinal length grows, and you have at the beginning more aerobes and the end more anaerobes. So, of course, age is an important factor that influences our microbiome. Well, second of all, what about nutrition? And we know that nutrition is a very important fact. If you, for example, look at complex carbohydrates like fibers, for example, they're resistant to enzymatic activity because then they come into the colon, and they're a very important resource for certain gut microbiota, for example, like Lectospira, Probiotics, and then they develop certain metabolites, and they have a host effect. For example, they might improve your inflammatory bowel disease, okay? And you can go through all this prebiotics, proteins, and lipids. All these dietary compounds must have an influence on our microbiome. So we can influence that. What about the brain? And the brain is very important. We know, I will show you 3 different diseases that have been associated with changes in the microbiome. And so we know that information's coming from the intestinal lumen might, through these neurons, actually affect the brain. And vice versa, changes in the brain might, through the HPA axis or through different neurons, again, have changes on our microbiome. So it's age, nutrition, and brain. What else? This is a very nice study that was published just a few days ago. And what they did, they looked at 15 finishers of the Boston Marathon and looked whether they found interesting changes in their microbiome. And yes, they did. They found this Veillonella species to get abundant as soon as the runners are done with the marathon. And they looked at different questions asking what are the risk factors why these species go away. And interesting, the only factor was time after the Boston Marathon. And then they actually isolated one Veillonella species from one of the runners, and what they did, they gave it to the mice. And what you can see here, those are the mice either treated with the Veillonella species or with a control group. And here you see the time to exhaustion, and you see here that before that, when they get treated with Veillonella species, they were kind of doing quite well. And then they did a crossover trial, and all of a sudden the other mice ran even faster. So this means that you might be able to improve your exercise by putting you Veillonella species into your colon, as the study was shown, and I think this is a very nice study. So then this is an Italian study. They looked at extreme longevity. They looked at people that were really old, turning 105 to 109. They found 24 people. And then they looked at their microbiome, and you see here, I told you about the core microbiota starting between 22 and 48, and then extreme longevity is actually associated with a different population. The core microbiome showing here shrinkage, and then you have like a subdominant fraction of other bacteria that get boosted. So even longevity is even associated with changes in the microbiome. So we have age, nutrition, exercise, and to be honest, there are more factors that infect our intestinal microbiota. So changes in the microbiome and association to diseases. I will give you a few examples of different diseases that have been shown to be associated with certain diseases. First of all, Alzheimer's disease. No one would maybe from the first point think Alzheimer's disease has anything to do with microbiota. But we know this is a neuroinflammatory state, okay? So if you have germ-free mice, and you see that in germ-free mice, you have less amyloid production over here, but as soon as the microbiota comes back, you have more amyloid production. And there have even been studies shown that maybe Helicobacter pylori might be an important pathogen in development of Alzheimer's disease. So eradication of Helicobacter might even help in Alzheimer's disease. So two other diseases that are important for the microbiota, it's autism and Parkinson's disease. And for autism, for example, there have been studies showing that might say that Clostridia species, one important microbiota, might be involved in the pathophysiology of autism, okay? And other findings were made for Parkinson's disease. Well, obesity is a very important text. This is a very busy picture, a busy slide. I will just show you that we know in obesity also we have changes in the microbial richness, we have changes in certain bacteria, we have mucus degradation, and this was found nicely in a study a couple of years ago saying that even obesity is associated with changes in the microbiome, and the microbiota might be indeed part of increasing your risk for obesity. So Crohn's disease, this is a disease I like to treat a lot of patients. This is a complex pathophysiology, and you see here genetic factors, you see environmental factors, and this is what happens. See, you have all the mycobacteria attached to the colon, and then they make it into the luminal wall, and here starts this chronic inflammation. And we know that also in Crohn's disease, the microbiome must be involved. And an indirect sign was shown in a very nice study. They looked at patients with Crohn's disease and children and asked the mother, how much courses of antibiotics did your child get during childhood? And then they looked up the data and found for Crohn's disease, the more antibiotic courses you were getting at early years, the higher is the risk that you develop Crohn's disease, okay? It's not the case for ulcerative colitis, that's a different disease, but for Crohn's disease there was this clear association, again showing that's another disease where the microbiome must be involved in its pathophysiology. And this is another very nice study published last year. They looked at patients that were treated with malignant melanoma undergoing a certain immunotherapy. And then they were able to find out that those patients with a certain microbiome responded a lot better to this therapy than the non-responders, and they had a totally different microbiome. And what they did then, they isolated the bacteria of the good responders and gave it to the mice. And all of a sudden, in the mice, you saw a reduced tumor growth and a better response to therapy. This means that the microbiome might even predict the response of chemotherapy and certain agents. And I think these are all very interesting findings. Well, the first main problem is when you look at diseases and changes in the microbiome is the following, is the chicken and the egg problem. So what is first? Is it first the disease there that makes changes in the microbiome that we see? Or is it the other way around? Is it first the microbiome that changes and then develops the disease? So this is one of the most important questions that we have to answer these days. And the second main problem is how can we actually influence our microbiome? What are the methods that we can do? And you know, many of us might maybe suffer from midlife crisis. And there's even a mice model looking how you can study midlife crisis. And what was found in this study over here, if you challenge mice and they have to go swim for a very long time, for 2 hours, young mice, they don't care. They don't develop any stress, as you see over here. But older mice, middle-aged mice, they develop stress. You see this bar over here means this is stress. But when those mice were treated with a prebiotic up front, inulin, they saw that the stress was reduced. Saying that for us, for men going in midlife crisis, maybe a probiotic treatment might actually be a nice way to get this better. Now this is irritable bowel syndrome. Maybe you've seen patients with that. We see a lot as a gastroenterologist, and we know clearly that this must be a disease where microbiome changes must be involved, because we have patients either having an infectious GI disease, they develop inflammatory bowel disease. And this is Rifaximin. Maybe some of you have known it's an antibiotic that treats gram-negative and gram-positive bacteria. And you can see here in this slide, it's better than placebo, but the changes are very small. So even in a disease like IBS, where I believe the microbiome must be involved, I treat those patients with antibiotics, and I see only very small changes compared to placebo. So this is the other second problem. How can we actually influence our microbiome? And the question is, how can we at first do this? And the second question is it always good, or does it even sometimes harm? And now I will show you two studies regarding this. This was a trial from a Dutch group, and they looked for patients with an acute pancreatitis, a severe inflammation of the pancreas. And they randomized these patients to either a probiotic treatment or placebo. And then they analyzed the data, and you see here, this is the mortality. So here's in this group, the red lines, those patients died earlier and a lot more compared to the other group. So everyone thought, well, maybe this is the probiotic group over here, and this is the placebo group, but it's totally different. So the patients in the probiotic group died earlier than the placebo patients, because the probiotic patients got, like, for example, intestinal wall, ischemia, and perforation, and that's why they died. So it's not saying every probiotic does help, it can sometimes even harm, and this is a very important problem. And this is another interesting study for gastroenterologists. When patients have colonoscopy, they come and ask, what can I do to restore my microbiome? Can I take some drugs or whatever? And this study actually looked at patients in mice after they had gotten an antibiotic treatment. And if you get an antibiotic treatment in human and mice, you hear complete diminishing of all the microbiota. They're all gone. And then the question was, what makes it to restore your microbiota? So we have a spontaneous recovery. Only the patients start eating again, doing just the regular things. It takes a little while, but then it recovers. And what they also compared with, what if we do a stool transplantation? I will show you later on what exactly this is. And they see a quite increase in the recovery. And then they looked, what happens if I give a probiotic? And all of a sudden you see the restoration takes a lot more time and is not as good as before. So also in this case, probiotics will not help. They even harm the restoration of your microbiota after antibiotic treatment. So how can we actually influence our intestinal microbiota? And I will show you the most important aspects that we have so far. And this is called fecal microbiota transplantation, and maybe you have heard of this, you know? This is a picture back from China in the 4th century. And you see here is the patient, and he's lying down and he's holding his body, probably not feeling well. It suggests he has like a gastroenteritis. And you see this guy over here, he gives him his stool samples, and it's not shown how, but somehow his stool samples are brought into this patient. So fecal microbiota transplantation has been done there for a long time. And I'll show you how this is done, you know. You have a donor, and you gives your feces. Of course, you check up front. And then you mix it just with sodium chloride, and then you blend it, and then you filtrate it just to make sure that there are no like fibers or something that might involve your endoscope. And then you can do the fecal microbiota transplantation either by endoscopy or by an oral capsule. And we do this in our clinic. This is how it's done. You see here the mixing and the filtration, and then we do a colonoscopy. And this is the transplantant, and then we just put it up into the colon. Okay, now the question is, where does it help? And there's one disease where it really helps perfectly, and this is the treatment of Clostridium difficile infection, a disease that's been quite frequent in hospitals all over the world. And this is a study from a Dutch group, and they looked at the efficacy. How good is it? And you know, in most of the guidelines, we treat those patients with vancomycin, that's an oral antibiotic. But as you can see here, the fecal microbiota transplantation was so much more effective that they stopped the study after half the patients, saying we cannot treat those patients with vancomycin anymore. The fecal microbiota transplantation is so much better. So this one disease is actually affected by changing in a microbiota so dramatical by this FMT. So the question is, are there other diseases that can be helped? And this is a recent study published from African children that are severely malnourished. And what they did here, they took the microbiota from a healthy child, and they isolated the microbiota from an unhealthy, underweight child, and gave it to the mice. So what happens? The microbiota from the healthy child lead to big and strong mice. And what happens with the microbiota from the unhealthy child? This leads to smaller mice not gaining weight, showing that the microbiota can actually affect your gaining weight. And they did additional experiments, and they again gave the microbiota from the unhealthy child to mice, and then they did a co-housing. They just gave regular mice with them, and all of a sudden you see you can restore your weight. And then they also cultured some microbiota, gave it to the unhealthy mice, and all of a sudden you see all these mice start growing again, saying that you might be able to treat undernutrition by microbiota from healthy children. So, and there's actually one case report on a patient with anorexia nervosa, and she was a patient have undergone a lot of different treatments for anorexia nervosa, and they treated this patient with fecal microbiota transplantation, and what they found here, over a period of 36 weeks, she gained about 14% of her weight again. So this case report ends up with a clear idea of we have to make good randomized trials to see whether we can treat undernutrition with fecal microbiota transplantation from healthy people. So the question is, does it always help, fecal microbiota transplantation? And maybe some of you are familiar with some 2 reports from the FDA. This is for the first time that there has been a patient death linked to fecal microbiota transplantation. Those were 2 patients treated with some immunosuppressive drugs, and they were actually infected by some multi-resistant bacteria that were not tested for in the stool before, and one of the patients died. So the FDA has now, and the German authorities also, made strict, clear inclusion criteria. What person can be the donor of the species, okay? Now we have to check for a lot of resistant bacteria and so on. So this will be a lot more difficult to find a donor for fecal microbiota transplantation. But before that, we thought FMT was not a problem without having much side effects. But the problem is, and if you look at the current data from clinical trials government, all over the world, there are more than 236 studies dealing with fecal microbiota transplantation in obesity, in anorexia nervosa, and other diseases, Crohn's disease, ulcerative colitis. So this is very interesting, but a cure it's not. But in Clostridium difficile, as I showed you, it's a very good approach to do this. Now let me please summarize my data in one slide. So I talked a lot about the microbiome, so that's why I will put it in the middle of this. I told you that we have a lot of factors that have an influence on our microbiome. It's the brain and stress, it's diet and lifestyle, genetics and inflammation, and also, of course, drugs. So if everything works well, we live in so-called oibiosis with our microbiome, and this must be or should be associated with health. If we're not living in good shape with our microbiome, this might lead to a factor called dysbiosis, okay? And this might be a relevant factor for autoimmune diseases, for obesity, for cancer, and for neurologic diseases like autism and Parkinson disease and so on. So now we have to answer this one question: which is the chicken and which is the egg? Is it first changes in the microbiome and then the disease, and vice versa? And I think in some of the diseases it will be the one way and the other ways around. And then last but not least, it will be of very much importance to find out whether we have microbiome-based interventions and treatments, either by prebiotics, probiotics, fecal microbiota transplantations, and so on. So I come to the end. Those are my references if you would like to be interested. And on the last slide, I will like to show you a little bit about the Waldfriede Hospital. It's an academic teaching center of the Charité. I came from the Charité 5 years ago, and I just heard Newsweek cured the Charité as to be the best hospital in Europe and one of the top 5 in the world. And I've been working there for 5 years now, and we have a, I think, very good gastroenterology and hepatology department with 2 colleagues that came from me with the Charité. We're doing a lot of endoscopic ultrasound, which is quite interesting. We work very close with our surgeons together. As Dr. Landis told us, we are currently for rectal surgery number 2 in Berlin and for colon number 3. And in a city like Berlin, where you have so many hospitals, it's a really tough situation. All the patients are really fight for. And we do a lot of clinical trials in IBD, phase 2 to 4, testing new biologics in IBD patients. And I'm glad to have 3 excellent study nurses that work with us. And I'm really proud that we have set up a Center for Nutrition and Preventive Medicine that is led by Amélie Kahn. She's a Bachelor of Science, and she has managed to arrange hospitations and some academic works for all these young people from all over the world. So if someone is interested and come and join us on nutrition in a hospital, we're very happy to join you. And last but not least, there's one person who is helping us in all the situation, and this is Bernd Voss. He's the head of our hospital, and he has given us great support to set up all these things, and without his help, we would not be getting organized all this. So I thank you very much for your invitation. Bye-bye.